हाँ जी। क्या टॉपिक आज?
फार्माकोजेनोमिक्स ये
ऊपर वाले
हाँ।
9 बजे इसी में कवर करोगे दोनों?
क्या चीज़?
2 है ना आपके कंटिन्यू?
2 कंटिन्यू है?
हाँ तो इसी में ही करोगे, कैसे करोगे?
मेरे को नहीं आइडिया 2 है क्या?
आपको कैसे है?
नहीं वो एक शायद
चलो अब
बाकी है।
थोड़ा तो ये दोनों हो ही जाएंगे इसी में
नहीं
से।
मैं फिर वो लेकर आती हूँ ना अपनी।
आपको नहीं पता, मेरे को तो
मेरे ख्याल से
मैं तो इस हिसाब से आया ना कि 8 बजे का भी है, एक 9 बजे का भी, मुझे ये पता नहीं है
मेरा ही है।
आपका ही है या किसका है।
मैंने देखा ही नहीं। मेरे पास तो एक ही मेल आई थी।
ठीक है कर लो। मेल आई है तो फिर तो कोई दिक्कत नहीं, क्योंकि मेल तो करंट होती है ना।
मैंने दिया।
ठीक है आपको मेल आई, कर लो इस चार्ट।
नहीं एक सेकंड मैं तो इसमें होगा वो दूसरा भी होगा वो भी खत्म कर देती हूँ। चेक कर लेती हूँ।
आपका ही है? मुझे नोट देकर आपका ही है? आपका ही?
इसमें देखिए स्लाइड वो एक और होगा शायद। इसमें पेन ड्राइव
नहीं नहीं कोई नहीं।
नहीं तो मिलेगा।
ये देखो
पर माइक्रो इकोनॉमिक्स करके होना चाहिए, नीचे जाएगा नीचे
इकोनॉमिक्स
ये
इंट्रोडक्शन
ना इसके नीचे पीई वाला जो है।
ही वाला।
हाँ
तो इसके बाद करें,
हाँ
दोनों है ना?
हाँ मेरे ख्याल से है, खोलिएगा एक बार।
हाँ वही है इकोनॉमिक्स। तो पहले कौन सा स्टार्ट हो रहा
वो जेनोमिक्स वाले ही होते हैं।
है?
ये विंडो खुली होगी ना, मुझे बस शिफ्ट करना होगा। ना ऊपर ये बस नीचे से मुझे
बस
सिर्फ
इसको
चेंज करना
इसको
होगा।
क्लिक कर लेना,
इसको
ठीक है ना?
ठीक।
तो ये फार्मा का इकोनॉमिक्स आ गया, जैसे
ठीक
दूसरा आ गया।
हो गया।
तो अभी ये वाला ना?
हाँ अभी ये वाला। Good morning everybody. The class we have today is on pharmacogenomics. We all know by now that there are multiple diseases which have a genetic component. Although the proportion of the genetic component in any particular disease may vary, normally it is said that this disease is totally inherited, like thalassemias and all or it could be an interaction of the disease and the environment, which leads to the disease phenotype or the expression of the disease, like in case of schizophrenia, where environment plays a role. So in this slide you can see that there are multiple levels at which the genes can interact with the environment or independently lead to diseases. Once we know that a disease can occur on account of some kind of genetic variation, the simple solution is that you vary that gene and you will be able to ameliorate the disease. But it is not really that simple, because the component of one particular gene to a particular disease may vary. So it could be few genes and environmental factors which could be contributing a large risk, or it could be many genes and the environmental factors which could be contributing to a smaller risk. So since we have a complex phenotype, we don't know what to expect in terms of which gene affects the occurrence of a particular disease to what extent, and what is the interaction with the environment. Although with the advent of all the new techniques wherein you can clone each and every gene, you can map the total genome, now there is some understanding that which all genes may be involved, but still the knowledge we have is quite minuscule. This is just an example. Leukemia was identified as a disease of the blood in 1950s, or it was assumed to be a disease of the blood in 1950s. In 1960s, it was discovered, or it was seen that leukemia, disease of the blood, could be leukemia or lymphoma. In 1970, we had 3 different types of leukemias and 2 different types of lymphomas: the chronic leukemia, acute leukemia, pre-leukemia, and indolent lymphoma, aggressive lymphoma. By 2007, there were 38 leukemia types identified and 51 lymphomas identified. Now it doesn't stop here. Even in these 38 types of leukemias, you had different subtypes. So what was the reason behind this? It was the genetic variation, and of course we know that survival may vary, and in this particular case the survival varied from 0% to nearly 70%. So what is AIIMS and omics? Genomics is when we are talking about all the genes, and pharmacogenomics, when we say, what we mean is that we can offer a choice of a personalized medicine. Personalized in the sense that we identify what is wrong at the gene level and we try to correct that particular thing. Now besides pharmacogenomics, there are other terminologies which are used. These are nutrigenomics, which helps you choose the best diet based on your genetic makeup. Then there is toxicogenomics, which can help predict toxicity based on genetic makeup. There is epigenomics. It takes into account all epigenetic changes in the genome. Transcriptomics, all the mRNAs and microarrays. Proteomics, all the proteins. Interactomics, all interactions between all proteins. And metabolomics, or metabonomics as they call it, which is all the metabolites based on your genetic makeup. So what is central to all this? It is your genome, or the genetic information that you have. Based on that, it is predictable what kind of diet would suit you, what kind of toxic effects you would experience with any particular drug or xenobiotic, what kind of medicine will suit you, what kind of proteins you are forming, what kind of metabolic abnormalities can occur or can be corrected. When pharmacogenomics was something which was coined quite late, but before that there was a term called pharmacogenetics which was prevalent. This came in as early as 1959. So what pharmacogenetics normally referred to was the role of genetics in drug responses, whereas pharmacogenomics was the science that allows us to predict a response to drugs based on an individual's genetic makeup. So basically the difference between these two is that the role has reversed. In this case, in pharmacogenetics, you would see a response and then you try to attribute it to some kind of a genetic difference. Now in case of pharmacogenomics, basically it is nothing but pharmacogenetics itself, but what happens with pharmacogenomics is that you know the genomic structure, or you know the genetic makeup of a person, and based on that you predict a response. So that is the difference between the two terms, but basically both these things, they do the same thing. They are basically working on the genetic makeup to predict a response, which could be anything, maybe efficacy or toxicity to a particular drug. So pharmacogenomics is the study of genome derived data including human genetic variation, RNA and protein expression differences to predict drug response in individual patients or group of patients. There is no universally accepted definition of either pharmacogenetics or pharmacogenomics. They are often used interchangeably. Pharmacogenetics, of course, is the older term, while pharmacogenomics is a newer science about how the systematic identification of all the human genes, their products, inter-individual variations, intra-individual variations in expression and function over time affects drug response and metabolism. The term pharmacogenomics was coined in connection with the Human Genome Project. Most use pharmacogenetics to depict the study of single genes and their effects on inter-individual differences, mainly in drug metabolism, and pharmacogenomics to depict the study of not just single genes but the functions and interactions of all genes in the genome in the overall variability of drugs response. So if you look at it this way, if there is a single variant, then you normally refer to it as a pharmacogenetic variation. But this single variant is contributing to a large single effect. But as the number of variants in genes or group of genes keep on increasing from small number to many variants in many genes, even though the effect is smaller, it comes under the purview of pharmacogenomics. So what are the examples of pharmacogenetics? Like there is a difference in acetylation, G6PD deficiency. These all used to come under the purview of pharmacogenetics. Now again, this gives you the same thing. When it was the pre-genomics time, or it was pharmacogenetics, then with a drug you have variation in some response, you call it the genotype, and you compare genetic polymorphisms in phenotypic groups. Okay, so you, based on the genotype, you compare the genetic polymorphisms. But when we talk about genomics, what you do is you do the genotyping in advance and you compare the phenotypes based on genotypic groups. So the role has basically reversed. Pharmacogenetics was defined as the study of how genetic variations affect the disposition of drugs, including their metabolism and transport and their safety and efficacy. Pharmacogenetics involved both pharmacokinetics as well as pharmacodynamics. So what is the goal of pharmacogenetics or pharmacogenomics? The whole idea behind going into all this omics and ethics is to maximize drug efficacy, minimize drug toxicity, predict patients who will respond to intervention, and aid in new drug development. So this is the basis for going into any of this. The next class would be on pharmacoeconomics and pharmacoepidemiology. So in that case also the basic goal is the same. What we want is maximum efficacy with minimal toxicity, minimal cost, have new drugs and a better response rate. So what is the hope of pharmacogenomics? That individuals' genetic makeup will allow selective use of medications such that efficacy is maximized and side effect is minimized. So basically you know that person A has gene A, B, C, D, E. He lacks F. So this particular drug would be good for him. On the other hand, you have person 2 who has A, B, C, F, but he lacks D and E. So in that case he is prone to this particular side effect. So you use a different drug. Now we know it's not only the genetic factors which affect an individual's drug response, but there may be other factors also like the physiological factors and environmental factors. But while genetic factors are stable and inherited, the other factors are mostly transient. For example, in other factors you would include the co-administered drugs, alcohol, dietary constituents, etc. And physiological factors like age, sex, disease, circadian rhythm, etc. So you know very well that what is the effect of these environmental and physiological factors, and you can try to control them to a certain extent. Now the genetic factors, they help you define that what are the therapeutic targets, what are the drug metabolizing enzymes or transporters and targets of ADRs, and based on that what is the difference in these targets which will help you maximize efficacy, identify the metabolism part so that you know how much dose is to be given, drug disposition, and once you are able to kind of optimize the metabolism and disposition, then toxicity automatically can be controlled. Because why toxicity happens? Toxicity happens because the levels exceed the required levels, or alternatively a person is prone to a particular thing. So if you know that if it is just a kinetic kind of a thing like metabolism and all, then if you know it, then you can accordingly adjust the dose. But if it's an iatrogenic kind of a reaction, then you can't do anything about it. Now what are the type of genetic variants that you encounter? You have single nucleotide polymorphisms, or the SNPs that we call, and indels. Indels is nothing but insertions and deletions. What are single nucleotide polymorphisms? This is a variation in a single nucleotide that occurs at a specific position in the genome, and this is the most common variation. Like you have a sequence AGGTCC and then suddenly you have AGGGCCC. So only one variant has been changed, but that may lead to change in response. Now, what are the types of SNPs or single nucleotide polymorphisms? You classify single nucleotide polymorphisms based on the area or the region where they are present. They may be present in the non-coding region wherein it would not have any impact, or they would be present in the coding region. So when they are present in the coding region, they could be either synonymous or they can be non-synonymous. And if they are non-synonymous, they can be missense or nonsense. We'll just define what is all this. So when a SNP is present in a coding region, it is termed as CSNPs. And in non-synonymous SNPs would result in nucleotide substitution that changes the amino acid codon. Okay. Now, amino acid codon means the 3 nucleotides which would code for a particular amino acid. So if that amino acid gets changed, then the protein automatically gets changed. For example, CYP3A5 deficiency occurs in 75% white and 50% black people because of SNP CYP3A5 star 3. Star refers to the allele. Okay, 6986A to G. So in this case, A is substituted by G. That introduces premature stop codon or a nonsense mutation and truncation of protein. A synonymous SNP will not change the amino acid codon but may result in changes in transcript stability and splicing. For example, polymorphism of ABCB1 that encodes for PGP polymorphism C3435T results in a change from a preferred codon for isoleucine to a less preferred codon. So basically in this case, the protein which is the amino acid which is formed has not been changed, but the stability has been affected. The non-coding SNPs take place in the non-coding sequence of DNA, can take place in promoter region, introns or intergenic region. They may affect transcription factor, binding, enhancers, transcript stability or splicing. So the example is VQRC1 gene which encodes for VQR, and warfarin is the target enzyme. SNP in promoter region of the gene is associated with warfarin sensitivity. We will be discussing this in detail. So what is the impact of single nucleotide polymorphisms? If it is outside a gene, there is no impact. In the gene coding sequence, change of base but not of amino acid can cause redundancy of genetic code. GCA to GCC both code for alanine. Change of amino acid, more or less impressive modification of function. It can be a loss or gain of function. If it is in the promoter region, increased or decreased transcription of the gene and protein expression. And in the mRNA 3' untranslated region, increased or decreased sensitivity to miRNA that inhibits translation and destabilize mRNA. Now we have a single nucleotide polymorphism database system, DBSNP, which is nothing but a free public archive for genetic variation within and across different species. So this is developed and hosted by the National Center for Biotechnology Information NCBI in collaboration with the National Human Genome Research Institute, that is NHGRI. And this contains a range of molecular variations, SNPs, short deletion and insertion polymorphisms. Every submitted variation receives a submitted SNP ID number. So what happens is that if any SNP is identified, then what people do is they submit it to a central national repository so that it can be documented and it can be accessed for use or for deriving that what will be affected or for further research. Then the other kind of genetic changes are indels or insertions and deletions. This is the second major type of polymorphism, deletion. Example is deletion. You understand that a particular area may have lesser number of base pairs. This is deletion. Here you see that in this particular region there were 4 A's and a T. Now we are left with this ATA has been deleted and we are just left with this. So the example is glutathione S transferase M1 polymorphism caused by deletion. Homozygous null individuals have only 50% of glutathione conjugating capacity of those with at least one copy of GSTM1 gene, the wild type. Wild type is the actual one. Then we have insertion. Insertion would have some additional amino acid inserted, or the sequence inserted. Here you see TG which has come in between this same sequence. So gene duplication of site 2d6 results in an ultra rapid type metabolizer phenotype. So these small changes can have a major impact on how a drug is handled, be it metabolism or be it toxicity. So genetics as a basis of variation in this drug response, we've already discussed. It could be pharmacodynamic or pharmacokinetic. So when it is pharmacodynamic, different responses to the same drug concentration. So basically you can, this is not visible here. So basically what happens is that if you know, then you can see that which signaling pathways are involved, or which particular enzymes or other factors like the channels which are affected. Then uncommon, qualitatively distinct adverse effects can also be seen. And when it is pharmacokinetic, then altering expression of proteins involved in ADME, that is absorption, distribution, metabolism and elimination. Now what is the impact on drug discovery? We have discussed it many times that this route of new medicine is very long, takes 11 to 15 years, and the patent life is 20 years, which implies that by the time you have the drug in market at the end of 15-16 years, you hardly have 4 to 5 years to recoup all the money that you have spent out here. So if there can be a mechanism of knowing who will respond and who will not respond, then probably you can cut down on expenses and a lot of time. Sometimes what happens is that even after these 11 to 15 years and 1 year in the market, the drug may need to be withdrawn because of some side effect which was missed out somewhere here. So if you have the genetic information and you can correlate that these are the mechanisms which are involved, then what you can do is right here itself you can go in for patients or subjects who satisfy the criteria for your drug. So that way a lot of time and money would be saved. So what pharmacogenomics can do is it can help in creating opportunities to increase the value of the drugs we develop using genetics, obtain greater understanding of the disease, predict disease severity, onset, progression, identify genetic subtypes of the disease, aid in discovery of new drug targets, help distinguish subgroups of patients who respond differently to drug treatment, and aid interpretation of clinical study results. This is the historical aspect. Now we have this online Mendelian in AIIMS catalog, an online catalog of human genes and genetic disorders. So it's similar to the kind of database that we have, and this is a collaborative project of John Hopkins National Human Genomic Research Institute and Institute of Genetic Medicine. Then there is the HapMap project. In HapMap project, there are an estimated 10 million SNPs with a frequency of 1%. HapMap project has genotyped Chinese, Japanese, African and European individuals. Now, what is the application of pharmacogenomics? When we talk about pharmacogenomics in drug discovery and development, we can choose the best targets depending on the disease genetics. We can understand the target variability. We can select responders, thereby improving early decision making, and also be able to predict efficacy and safety based on the pharmacogenetics. Identification of genes conferring to individuals who carry them a better sensitivity to the therapeutic action of a medicine or a better tolerance, and genotyping before inclusion in a clinical trial can increase the statistical power and decrease the cost. This is what we just discussed. Simultaneous marketing of a medicinal product and availability of a genetic test to identify patients to treat. Restriction of the market but higher price since efficacy is optimized. So this is how the drug development process can be impacted by using pharmacogenomics. We have some FDA approved pharmacogenetic tests like for TPMT. If you are going to use 6-mercaptopurine, which can cause toxicity, CYP2D6 tamoxifen decreases efficacy, UGT1A1 gene for irinotectin for toxicity again, then CYP2D6 for codeine if we are looking from the analgesic component. But these genes all modulate the pharmacokinetics. Now TPMT, it's a main metabolizer of chemotherapeutic agents like 6-mercaptopurine and azathioprine, which is used mainly in blood-based malignancies, and TPMT deficiency leads to severe toxicity associated with the treatment and potential mortality. So if you manage to screen the patient, then you can decide whether this patient is a candidate for these drugs or not. Now this is just to emphasize the same fact that individuals respond differently, like if you have a whole group. So if you are using without identifying that who would be a suitable candidate, then we can have a lot of toxicity. But if you do the screening, then you can find out that which are the patients who can take it without any kind of dose adjustment. There can be some patients which may need a lower dose and still show you the efficacy, and there can be a proportion of patients who are such poor metabolizers that they can they can die because of it. So it can be avoided in these cases, but in cases where dose reduction can be a choice, the drug can be used at a lesser dose, and then we of course have a pool of patients who can be given the normal doses. The other example is the cytochrome oxidase P450 enzymes. You know, these are involved mainly in metabolism. We have 57 different active genes in 17 different families. CYP1, CYP2, CYP3 are primarily involved in drug metabolism. Then CYP2A6, CYP2B6, 2C9, 2C19, 2D6, 2E1 and 3A4 are responsible for metabolizing most clinically important drugs. So here you see that poor metabolizer incidence can occur in a small percentage of patients for these different variants, and if you identify these different variants, you can decide whether they can be given these particular drugs or not, or they will have toxicity. So these are different classes of drugs. Now 2C9 is important. It has all NSAIDs, oral hypoglycemic agents, ARBs, warfarin, phenytoin. They are all metabolized by site 2C9, and the poor metabolizer incidence is 1 to 3% Caucasians. Then we have 2D6, which metabolizes antidepressants, beta blockers, antipsychotics, chlorpheniramine, codeine, dextromethorphan, ondansetron, lidocaine, a number of drugs of different classes, but the poor metabolizer incidence is to the extent of 5 to 10% Caucasians. In 2C19, we have 2 to 4% African Americans, 3 to 5% Caucasians, and 15 to 20% Asians. So this I think we can skip. We know that what is the effect of metabolic rate on drug dosage. If it is a pro-drug, the efficacy would be decreased. If it is active drug, inactivated by metabolism, it will have a better efficacy. So that depending upon the phenotype. Now this is about warfarin, the VQRC1 component. Warfarin ranks number 1 in total mentions of deaths for drugs causing adverse events. Now till that point it was the metabolism part. Now we come to the adverse event component. It ranks among the top drugs associated hospital emergency room visits for bleeding. Overall frequency of major bleeding ranges from 2% to 6%. Minor bleeding event rates in randomized controlled trials of new anticoagulants has been as high as 29% per year. A lot of people have died because of warfarin. So what is normally done is that to maintain warfarin in a therapeutic range, the patient is advised to monitor the INR, and based on the INR you try to minimize the bleeding risk, and also the risk of thromboembolic events by maintaining the INR in a particular range, that is between 2 to 4. You try to maintain the INR in this particular range so that the coagulation also takes place, there is no bleeding risk. Now how the genetic component comes into play. Warfarin levels depend on two enzymes, site 2C9 and VQRC1, and site 2C9 genotyping can help you decide that whether this particular patient can be affected. Now this is the frequency of VQRC1 alleles in various populations. These are the alleles which are present. This is a G2A, if you recall, when we talked about the SNPs, then we talked about this. This is G2A, AA, AG and GG. 3 different variants have been seen. Caucasians, Spanish, Chinese and Africans. Chinese have mostly the AA variant. So these people may need a lower dose of warfarin as compared to the Caucasians, Spanish and Africans. So what genetic analysis permits is a more rapid determination of stable therapeutic dose, better prediction of dose than clinical methods alone, applicable to 70 to 75% of patients not in controlled anticoagulation centers, reduces between 4,500 and 22,000 serious bleeding events annually, and genetic testing is now required by FDA before warfarin can be administered. There is another anticoagulant clopidogrel, which also has alleles. These are the CYP2C19 alleles, and again you have the different populations. Then there is Herceptin. This is a drug which is used in breast cancer. In a normal breast tissue cell, the HER2 gene is expressing cell surface receptors required for normal cell growth. In certain types of breast cancers, the HER2 gene is overexpressing this cell surface receptor, contributing to cancerous cell growth. This is the frequency is nearly 30%. So Herceptin is an antibody that blocks the cell surface receptor and thereby prevents further growth, and thereby it slows down the progression of the disease. So if you profile the HER2 gene, then you can determine whether this particular patient is a candidate for Herceptin or not. So this is the list of certain drugs which you can say can be personalized based on identifying the genetic makeup, like Herceptin we've just discussed. Then there is Erbitux, which is used in colorectal cancer and the target is EGFR. Then there is Tarceva for lung cancer, Strattera for attention deficit hyperactivity disorder, 6-MP of course TPMT, then for antivirals, that is resistance based on form of HIV. But the cost of genotyping is quite high, and it really doesn't make sense to go in for one single kind of a genotyping. It has been suggested that it's better to profile more genes at a single time, because that will bring down the cost. And besides the cost, the other thing is that sometimes there may not be enough time to wait for the results to come in before you start a treatment. So one of the suggestions has been that if you have the genetic profile of a patient, which is of course not going to change, so based on that genetic profile you can predict that which drug would be useful, which would not be useful. So that would be like a one-time kind of an effort, and then you can screen for multiple SNPs, and based on the results of that screen, if the need be, then drugs can be decided. So why pharmacogenomics is not widely used in the clinics? Because it requires a shift in attitude that not one dose fits all. There are paucities of studies demonstrating improved clinical benefit from use of pharmacogenomic data in many cases, although there are certain cases, like we talked about the examples that we have given, where this is not a problem. There is still much to be learned. Even some of the black box warning currently on drug labels may be overcalls of importance, and genome-wide interrogation will likely be important to get the entire picture, because if you recall the initial slides, it was not just one gene or two genes which were interacting to give a particular phenotype, but it could be multiple genes, and we are still in the process of unearthing that what all interacts. And then there is a major question about ethics of DNA databasing because there is a view that this may lead to some kind of discrimination, and anybody's DNA database is his particular thing and it should not be for public use. So genetic variation contributes to individual differences in drug response phenotype at every pharmacological step. So this forms the basis of precision medicine. Through individualized treatments, we can have better, safer drugs the first time itself. That is, if we apply the genomics to drug development process, we can have more accurate methods of determining appropriate drug dosages. If we know the makeup and how the patient is going to metabolize, we can determine the dose. Pharmacogenomics offers opportunities to understand the genetic architecture of drug response, and of course, if we want to study the responses also, we can go in for genomics. So this is all about pharmacogenomics. The next class we have is on pharmacoeconomics. So when we look at this term pharmacoeconomics, we know that pharmaco is related to the drug and economics will have something to do with money, right? So now money is not just the patient's money, but it could be the provider's money also, it could be the government money also. So you need a lot of pharmacoeconomics research because particularly in deciding the treatment which are meant for masses, you would want to go in for the best treatment possible, but at the same time, if the government is giving the treatment for free, then they would want that they have limited resources, so those resources should be distributed equitably among people. So considering that there are a lot of mass immunization programs, there are massive drug eradication programs, there are programs for tuberculosis management, a lot of programs which keep on running throughout the world, and most of them may be government sponsored, or if it is not a government sponsored program, the patient is paying out of his or her pocket, or if the patient is not paying out of his or her pocket, it may be the insurance company which is paying out of their pocket. So basically there is a lot of impetus on pharmacoeconomics so that you have the best possible treatment in the least possible amount of cost. Now when we talk about cost, we are talking about many different costs. Like the first thing that comes to the mind is that the cost for the drug. So when we actually get down to calculating the cost, we are not just calculating the cost of the drug, that is only a very small component of the total cost which comes out, but what we are going to do is we are going to factor in many other indirect costs also. So basically the cost of the drug or the cost of hospitalization or cost of the test, they can be a direct cost, but there are many indirect costs also which are incurred on account of drug treatment. These could be that the patient has to come from his home to get the treatment. Like if for a particular program the patient has to come to the hospital every day, he is utilizing his own vehicle or he is using public transport or something, then he tends to spend some money. So even though the cost of the drug may not be much, but the cost of ancillaries, that is the amount of money he spent in coming, the time that he spends, or if somebody is accompanying him and somebody has to take leave from office or to leave work and come along with the patient, then the loss in wages which occurs. So all these costs, they need to be accounted for. And why we need to account for all this is because again, we want to maximize the use of resources. So how do you define pharmacoeconomics? This term was used first by Ray Townsend in 1986, and pharmacoeconomics is defined as the discipline of placing a value on drug therapy. So pharmacoeconomics is the discipline concerned with optimal allocation of resources to maximize population health from the use of medicines. It can also be defined as the scientific discipline that evaluates clinical, economic, and humanistic aspects of pharmaceutical products, services, and programs, as well as other healthcare interventions to provide healthcare decision makers, providers, and patients with valuable information for optimal outcomes and the allocation of healthcare resources. So in this definition, each and every word is very critical. You need an optimal outcome for the allocation of healthcare resources. Now this is just an example to illustrate what we were talking about. When you compare the IgIV with conventional immunosuppressive therapy, IgIV per se has more cost per unit, but it does not have any major side effect. So the cost of treatment will be only the cost of drug. Whereas the conventional therapy, it will be less cost per unit, but major side effects, which can even lead to death or prolonged hospitalization. So in case of the conventional therapy, the cost of treatment will be cost of the drug plus cost of management of side effects. So this may come out to be more. In case the patient dies, then the cost is much more. So how we do an analysis, we have the pharmacoeconomics quadrant. In the first quadrant, we put in the new treatment is more effective and more expensive. The second quadrant has the new treatment which is more effective and less expensive. Then there is a new treatment which is less effective and less expensive. And then there is the new treatment which is less effective and more expensive. So these are the different choices you may be faced with. So that you have to choose that which one of this is to be picked up. Now these are some definitions which you should know. It's the perspective. Perspective is the way of assessing cost and consequences. Cost is the value of the resources consumed by a program or drug therapy of interest. Consequences, the effects, outputs or outcomes of the program or drug therapy of interest. So when we talk about the perspective, then of course the first and foremost is the patient, but besides the patient, we have the provider, we have the society, and we have the payer. Now when we talk about the patient's perspective, what he will look for is the effectiveness, safety, and the cost. When we talk about the provider, the criteria are the cost and the efficacy. That is, we try to drive a balance between cost and efficacy. When we talk about the society, then we are talking about the life expectancy, disease burden, and the cost. And when we talk about the payer, the cost and the efficiency. So for all these four people, the perspectives may be different. Cost of course is common to all of them, but besides the cost, what they look for is different. So if you look at the cost, you can have different types of cost. The direct medical cost, that is medications, supplies, lab tests, healthcare professionals' time and hospitalization. Then there are direct non-medical costs like transportation, food, family care, home aids. Then there are indirect costs, lost wages on account of morbidity or income foregone because of premature death, that is mortality. Then there are some intangible costs like the pain, suffering, inconvenience and the grief which occurs to a patient. And then there are the opportunity cost, lost opportunity or the revenue foregone. So these are the different categories of cost, and you have to balance all these categories to arrive at a perfect medicine for a patient. Then we talk about the consequences. There are the economic outcomes, clinical outcomes and humanistic outcomes. The economic outcomes take into account the direct, indirect and intangible costs compared with the consequences of medical treatment alternatives. Clinical outcomes, they take into account medical events that occur as a result of disease or treatment, example safety and efficacy endpoints. And humanistic outcomes, they take into account the consequences of the disease or treatment on patient functional status or quality of life, like physical function, social function, general health and well-being and life satisfaction. So we may have positive consequences, that is desired effect of a drug, efficacy or effectiveness, manifested as cases cured, life years gained or improved health related quality of life. Or we can have negative consequences, the undesired or adverse effects of a drug, manifested as a treatment failure, an adverse drug reaction, a drug toxicity or even death. Then there are the intermediate consequences. These are proxies predictive of final outcomes and reduces the cost and time required to conduct a trial. So we do two different types of pharmacoeconomic analysis, the economic and the humanistic. In the economic analysis, you take into consideration the cost benefit, cost effectiveness, cost minimization and cost utility. In the humanistic component, you take into account the quality of life, patient satisfaction and patient preferences. Then there is something called the cost of illness evaluation. It identifies and estimates the overall cost of a particular disease for a defined population, that is burden of illness, example burden or cost of Alzheimer's disease. And this can determine the relative value of a treatment or prevention strategy. This is not used to compare competing treatment alternatives. Then we have the cost minimization analysis. This helps in determination of the least costly alternative when comparing two or more treatment alternatives. When comparing two or more therapeutically equivalent agents or alternate dosing regimes of the same agent. For example, introduce generic prescribing rather than by brand name, which would achieve the same level of benefit at reduced cost. It shows only a cost savings of one program or treatment over another, and it cannot be used to evaluate programs or therapies that lead to different outcomes. Then there is the cost benefit analysis. This is the identification, measurement and comparison of the benefits and costs of a program or treatment alternatives. So you calculate the benefit to cost ratio. If it is more than 1, the program or treatment is of value. If it is equal to 1, then the benefit equals the cost. If it is less than 1, the program or treatment is not economically beneficial. So this is used for nationwide immunization programs. They can be fully costed in terms of resource utilization consumed in running the program. And valuation of outcomes such as productivity and quality of life is difficult. Then we have the cost effectiveness analysis. It takes into consideration health benefits and resources used by competing healthcare programs, and outcomes are lives saved, cases cured and life expectancy. So you have a formula for doing this. This is the formula. So you compare the costs of treatments or two programs and the effectiveness in percent terms. For example, diuretic hydrochlorothiazide may be most inexpensive treatment for hypertension, but it often requires a potassium supplement. And this cost effectiveness analysis is primarily used to set public policies regarding the use of pharmaceutical products, for example, national formularies, etc. Then there is the cost utility analysis. This compares treatment alternatives that integrates patient preferences and health related quality of life. So in this case you define it in terms of QALYs or quality adjusted life years. This represents the number of full years at full health that are valued equivalently to the numbers of years as experienced. So again there are different formulas for calculating these QALYs. But there is a lack of agreement on measuring utilities. There is difficulty comparing QALYs across patients and populations, and there is difficulty in quantifying patient preferences. Then there are the humanistic evaluation methods. Those were the economic methods. Methods for evaluating the impact of disease and treatment of disease on a patient's health-related quality of life, patient preferences and patient satisfaction. Health-related quality of life is the assessment of the functional effects of illness and its consequent therapy as perceived by the patient. Measurement of HRQOL usually is achieved through the use of patient-completed questionnaires. The next thing we need to discuss is pharmacoepidemiology. Pharmacoepidemiology is nothing but the study of the use of and the effect of drugs in large numbers of populations. And the scope of pharmacoepidemiology is the effect of beneficial effects as well as the adverse effects. So why we need to go into pharmacoepidemiology? Because we know that we have aging population, there are multiple diseases, chronic diseases, combination treatments are used, there are complex regimes, there are variations in practices, there is monitoring, surveillance. So we need to obtain data for all this so as to be able to optimize treatment or treatment guidelines or even the formularies. So pharmacoepidemiology is basically a blanket term and it will take into its fold all pharmacovigilance, pharmacoeconomics, pharmacogenomics, everything would come under pharmacoepidemiology. This all I think you know that there are multiple gaps. What is the effect of a drug in a large population, in the elderly, in children, in pregnancy, in combination with other drugs as compared with therapies, in presence of comorbidities, in ethnic groups, in patients with differing clinical parameters, pharmacokinetics, ADME, off-label prescribing. So what are the risks and what are the benefits? So pharmacoepidemiology encompasses everything: pharmacovigilance, pharmacoeconomics, pharmacogenomics, rational drug use, clinical pharmacology, clinical epidemiology. It's a blanket term. So basically it's a research discipline, and who does the research? This research is generated by academic researchers, drug industry, medical organizations, government and healthcare providers. In India we have pharmacovigilance, which is most common. We know we have AIIMSs and they are generating data or they are recording data on occurrence of all side effects or adverse reactions. Then there are drug utilization and rational drug use studies. There is pharmacoeconomics studies. There are evidence-based medicine meta-analysis and pharmacogenomics. Then how drugs safety evaluation. So what you look for is that all these adverse drug reactions, what are the various factors which are involved, what can be attributed to the drug, what cannot be attributed to the drug, like disease, genetics, other drugs, compliance, environment, diet, other factors. This we know. How we do drug safety data analysis. We characterize the risk, we assess the risk, minimize and communicate, measure effectiveness. So the data is generated in trials, in spontaneous reports, literature, epidemiological studies. We'll just skip the examples. So these are the tools which are used. We have active surveillance, passive surveillance, and we have comparative observational studies. Passive surveillance is the spontaneous ADR reporting. The AIIMSs, they do this. Active surveillance is sentinel site surveillance, hospitals, pharmacies, nursing homes, etc. Intensive monitoring schemes, focused ADR monitoring, prescription event monitoring, and disease registries. Then there are comparative observational studies like cross-sectional survey, case control studies, cohort studies, large simple safety trials, and drug utilization studies. So risk management in drug development, we've discussed it many times. What are the components of a risk management plan? The safety specifications, the pharmacovigilance plan, an evaluation of the need for risk minimization activities, and if there is need for additional risk minimization activities. Risk maps would be required when nature and rate of known risk versus benefits is of concern. Adverse effects are serious yet preventable. Probability of benefit in special populations. So how this is carried out? Targeted education and outreach to communicate risk and appropriate safety behaviors to healthcare practitioners or patients. Reminder systems or forms to foster reduced risk prescribing and use. Performance linked access systems. This is the iPledge program. So this is all about pharmacoeconomics and pharmacoepidemiology. जब ना क्लास चल रही हो तो एसी बढ़ा दिया करिए, मुझे एकदम से चक्कर आना शुरू हो गया। स्क्रीन में तो चक्कर आना शुरू हो गया, तो एसी बढ़ा दिया करिए, वरना थोड़ा ठंडा लगता है।
एसी का मेंटेन रखा है थोड़ा मतलब एक हिसाब से,
इसके बाद
कूलिंग से भी कुछ लगाते हैं ना, इस हिसाब से मैंने कुछ रखा है।
वो शायद गर्म था या क्या, तो चक्कर आना शुरू हो गया।
नहीं गर्म तो